diagnostic and therapeutic conundrum. And some of these patients we may be seeing only once in a lifetime, and by sharing what we saw with the others, it leads to propagation of knowledge. And every patient teaches us only if we observe and not just see, listen and not just hear, as they say. And so we will be better armed and primed for our future practice. I am very fortunate to have a battery of distinguished colleagues, Dr. N.S. Muralidhar, Dr. A.S. Guruprasad, Dr. Mahesh and Dr. Krishna Armurthy to assist me in conducting this instruction course. Without much ado, I would now request Dr. Krishna to present his 2 cases.
He came to us with the complaints of diminution of vision in the left eye of about 1 month's duration. He was diagnosed elsewhere to have CMV retinitis of the left eye. His CD4 counts were 44. He had just been started on heart therapy and also on antituberculous therapy. On examination, his best corrected visual acuity in the right eye was 6/6. He was nil light perception in the left eye. The right eye was normal. The left eye had a bullous retinal detachment and vitritis. Further details could not be made out very clearly because of the dense vitritis. A B scan was done. B scan showed a post-funnel retinal detachment with subretinal echoes. This picture did not fit into any of the normal things that we see in HIV positive individuals. It looked more like a masquerade. So we suggested that we should go ahead with a retinal biopsy. The patient understood, because the nil light perception is a thing which you don't see with CMV retinitis unless the optic disc is completely burnt out. And so we suggested a retinal biopsy. The patient did undergo a retinal biopsy. The retinal biopsy showed, on histopathology you can see that there were his malignant lymphoid cells. And have a pointer. There's malignant lymphoid cells, and immunohistochemistry with a pan B cell marker showed that it was positive for that, so it was a B cell lymphoma. It was diagnosed as a non-Hodgkin's B cell lymphoma. It was purely intraocular, there were no CNS lesions. He was investigated for that. Patient was advised radiotherapy and chemotherapy. He underwent 6 cycles of chemotherapy, and 12 months later he was doing pretty well. He came back to us 3 years later. He had a white mass lesion on the eye now. He had a white mass lesion which looks like a squamous cell carcinoma. His CD4 at this time was 380. It looked clinically like a squamous cell carcinoma. We suggested enucleation along with a white conjunctival resection. Patient underwent the same, and we can see here that there is a lot of conjunctival dysplasia, and there's also early formation of squamous nest, suggestive of a squamous cell carcinoma. There's also areas of necrosis, intraocular necrosis, which could be post-radiotherapy, and there's also some amount of osseous bone formation in the coats of the eye, which is quite characteristic of Thesical eyes. This eye was Thesical by now. The second case is a 42-year-old, again HIV positive male. He came to us with history of diplopia and drooping of the left upper eyelid of 2 weeks duration. He also complained of a mild deviation of the angle of the mouth to the left side and pain in the left eye. He had had a normal ocular examination about a month previously. He was on heart therapy. His CD4 was 178 presently. On examination, he had a complete left third cranial nerve palsy and a right partial lower motor neuron palsy. CT scan did show that there was a large mass lesion involving the right maxillary antrum. It had extended temporally, eroding the bone, and it had also extended posteriorly intracranially. He also had multiple small firm cervical lymph nodes which were palpable. His respiratory, otorhinolaryngological, cardiac and abdominal examinations were normal. His chest X-ray, however, showed a right-sided pleural effusion. However, a pleural tap did not indicate any malignancy or tuberculosis. So a nasoendoscopic biopsy of the lesion was done, and HNE showed a poorly differentiated malignant neoplasm. Immunohistochemistry for leukocyte common antigen was positive for 50% of the cells. LCA is done for NK cells, natural killer cells. And CD3 positivity for 30% of the malignant cells. This is again indicates a T cell origin because CD3 is T cell marker. Cytokeratin and CD20 were negative. Cytokeratin is for squamous cell origin. CD20 is for B cell origin. Both of them were negative. However, Epstein-Barr virus was strongly positive. This is the malignant dysplastic malignancy that we see. LCA common for about 50% of the cells. CD3 positivity for 30% of the cells, and Epstein-Barr strongly positive. So here we had a NK T cell lymphoma of a nasal type, which is quite a rare tumor. He underwent a bone marrow aspiration, and it showed atypical lymphoid cells which were infiltrating the marrow. He was diagnosed as stage 4 non-Hodgkin's lymphoma. He was advised low-dose chemotherapy with the following drugs. He developed complete blindness for like a few weeks, and he expired before the second cycle of chemotherapy. So here we had two cases of an unusual presentation of malignancies in HIV. Of course, the role of viruses in malignancies in the heart era in HIV individuals is much debated already. In case 1, we had 2 successive ocular malignancies in the same person, in the same eye, both with a favorable outcome. He had an intraocular lymphoma. Lymphomas in HIV setting are known to be associated with Epstein-Barr virus infections because when the immunity comes down, EBV does take over and there is an abnormal proliferation. So, though in the first case we did not hit the nail on the head and identify EBV, but literature does say that EBV is associated with that. The CD4 counts were very low when he developed the lymphoma. Next, he subsequently developed a squamous cell carcinoma. Squamous cell carcinomas in the setting of HIV, again, you see more commonly because possibly of the human papillomavirus. But in this case, it was also compounded by the fact that he had undergone radiotherapy, and also because of the climate in which we are, tropical climate, it increases the incidence of squamous cell carcinomas. In case 2, we saw a very rare type of a lymphoma, and here the role of Epstein-Barr virus was nailed by immunohistochemistry, and because of the aggressive nature of this tumor, the patient had a very poor prognosis. The second series of cases is again which develops in immunocompromised individuals. The first case of which is a 30-year-old male gentleman. He came to us with slowly deteriorating vision, which he complained as basically tunnel vision in both eyes, which had come down to counting finger 1 meter since the last 1 year. He was a known case of HIV for the last 6 years. He was not on any treatment. His CD4 counts were 120. His visual acuity was counting finger 1 meter in both eyes. The pupils were mid-dilated and sluggishly reacting in both eyes. His fundus showed something like this, which is like optic atrophy in both the eyes. His visual fields, which were done about 2 or 3 months ago elsewhere, showed a gross concentric constriction of the visual fields. He could not do the fields now at this stage. His visual evoked potential showed a delay in latency as well as a small amplitude in the P wave. This was also done previously. Vision after heart. So at this point in time, basically we investigated him thoroughly and we didn't find any reason why he should have optic atrophy. There was nothing we could offer to him. But since his CD4 was about 120, he was put on heart therapy. He started heart, and about a few months later he started improving, and at 7 months he had vision of 618 and 612 in the right and left eye. And the patient was pretty sure that his visual improvement started with heart therapy. Case 2 was a girl, 13-year-old girl, who came with, actually no complaint. She came just for routine examination. Her disc in the right eye looked something like this. In the left eye, she had optic atrophy. Vision was 6/9 in the right eye. Left eye counting finger half meter. She had not noticed the drop in the left eye vision. The CD4 counts was 287 at this point in time. Advised the fields for her. Left eye, she could not do the fields. Right eye fields showed grossly concentric visual fields. At this point in time, we again investigated it thoroughly, couldn't identify a cause for the optic atrophy. But by now we were pleasantly surprised by the outcome of the previous case. So I suggested to the treating physician, why not start her on heart? The physician was not very clear. She said, no, there's no other indication to start heart therapy in her yet. But on insistence, they did start her on heart therapy. And sure enough, after 4 months after starting therapy, her visual fields did improve. Her, the field of vision had improved. This was about 4 months later. And about 10 months later, the fields further improved and her vision was 6/6 in the right eye. The left eye, however, did not improve any further. We did a retinal nerve fiber layer analysis right through on her, and all along the retinal nerve fiber analysis was normal in both eyes. Even in the optic atrophy eye, there was no reduction in nerve fiber layer thickness. All these tests were actually done on both these patients to rule out possible infective etiologies. Serology was done for syphilis and toxoplasmosis. A chest X-ray and 1-2 was done to rule out tuberculosis. A CSF tap to rule out tuberculosis, tubercular meningitis, cryptococcosis, syphilis, and herpes simplex varicella and cytomegalovirus were ruled out. A CT scan was done to rule out intracranial space-occupying lesion. And a diagnosis of primary HIV optic neuropathy, which is basically a diagnosis of exclusion, was done. To discuss these two cases, primary optic neuropathy in a HIV positive patient is probably due to direct invasion of the HIV virus. We understand that the HIV virus, or we used to understand that the HIV virus does not cause any ocular lesion apart from the corneal spots that we see. Most of them are because of opportunistic infections, but this possibly is one condition where the HIV virus directly has a role. There is some indirect evidence in CNS to show that this could be happening, and if we consider that the optic nerve is an extension of CNS, we can extrapolate the same reasons here. And this was substantiated by the fact that there was improvement in vision and visual fields after starting heart therapy alone. There was no other therapy, no steroid, nothing else which was started. So this was one thing. But we did see that there was a very non-uniform improvement in vision after heart therapy. So then we need to say that probably the optic nerve passes, damage happens through two phases. One, there is an acute phase where there's a loss of nerve function, but there's no complete destruction of the nerves. This is where there is a marked improvement in vision after starting heart therapy. Then there's a chronic phase, which as we saw in the girl's case in the left eye, where there is irreversible loss of nerve function. That is, there's no improvement even after starting heart therapy. The visual fields were not described in primary HIV optic neuropathy before, but we saw that the constriction of visual fields was the most common visual field defect. Field changes may be noted in an otherwise asymptomatic eye, as we saw in one of our patients who were not even aware that she had such a gross change in fields. So routine visual field testing is in place. The retinal nerve fiber layer thickness was normal in the child that we saw. I've just shown two representative cases. Actually, we have a series of 8 cases which we have presented in the IJO. But in all of them, we saw that the retinal nerve fiber layer thickness was normal. It was not reduced. This could possibly be because this could be an infiltrative optic neuropathy. That means there could be infiltration of the nerves with either viral particles or inflammatory cells. That could be the reason why the thickness is not reduced. So to conclude, one is there needs to be an awareness of a condition called a primary HIV optic neuropathy among the general ophthalmologists, because this has a good prognosis if it is detected early and treated early. Primary HIV optic neuropathy is probably an indication to start heart therapy, because there are very clear guidelines as to when you start heart therapy, but this possibly is one other indication which we need to think of. Constriction of visual fields was the most common visual field abnormality which we saw. However, further histopathological and clinical studies are required to study the pathogenesis of this condition. Thank you.
Thanks, Dr. Krishnamurthy. For those of you who may not know who Dr. Krishnamurthy is, he heads the vitreoretinal department at Prabha Clinic, and he has done his fellowship from Shankar Netralaya, Chennai. I now invite Dr. Guru Prasad to present his patients. Dr. Guru Prasad is Chief of Vitreoretinal Services at M.M. Joshi Eye Hospital. He too has had a fellowship at Shankar Netralaya.
Thank you, Dr. Kumar, for considering me to be part of this instructive course. I've always enjoyed helping over the instructional courses. My first instructive case is a post-operative uveitis, and what time it took and what it took to solve this mystery. No financial disclosures. This is a story of a 44-year-old female who came to us with a history of diminution of vision for distance in both eyes. She had floaters in the right eye. Her main complaint was actually floaters, which are underlined there. Her vision was 6/9 and 6 in each eye. She had thin posterior subcapsular cataracts in both the eyes, and the fundus did show vitreous opacities in the right eye, but otherwise it was relatively normal. So because of the cataract, without giving much importance to the symptoms of floaters, we did a phaco foldable, silicone foldable IOL for her in the right eye, which was supposedly uneventful. She was fine on the day 2. When she came back on day 9, she did have floaters still, and she also started complaining of occasional pain in the right eye. At that time, the vision was 6/9 and N6, not better than what her preoperative visual acuity was. But we noted that there was a PCR. I'm sorry I don't have a photograph of the segment of this patient, but this PCR was there but was not mentioned in the operation notes. The surgeon who had operated had not mentioned that there was a PC rent during the surgery. On fundus examination, she had vitreous opacities inferiorly, which, because of the pre-existing floater history that she gave before surgery, was diagnosed as vitreous hemorrhage, presumably due to PVD. So it was diagnosed as a PVD-induced vitreous hemorrhage and passed off as vitreous hemorrhage. On subsequent follow-up, she came on first month, second month. Thereafter, she was seen again on the 4th month. Each time she was unhappy. Each time she was complaining of some heaviness in the eye. The floaters still persisted, but irritability and heaviness in the eye was something that she had continuously been complaining about. On the 5th month follow-up, she was found to have, apart from the floaters and the heaviness in the eye, intraocular pressure rise up to 52 millimeters of mercury, which was, however, controlled medically within a short time. And when she came back at the 7th month follow-up, her IOP was controlled without any medication. See, a patient with a simple cataract had to keep coming to us for 7 months until now, until this slide. You will see further how many more times she has come. Still, she was not happy. The floaters were still persisting, and on fundus examination, resolving vitreous opacities were there. It was no longer looking like a hemorrhage now, it was looking like retained lens fragments. So, on the basis of the diagnosis of a retained lens fragment in the eye causing uveitis, so we gave her posterior subcutaneous triamcinolone as an empirical treatment or as a stopgap treatment, and she had temporary relief with that. Finally, she was seen by me on the 10th month follow-up. Till the 10th month, I had not seen this patient. She was being followed up by the juniors, and I decided that since she had had enough, we should do a vitrectomy and get rid of this causative factor of the retained lens fragments. And I did not do this vitrectomy. It was actually done by my colleague, and this was done with a wide-angle lens with good visualization of the periphery. And after clearing all the fragments that had dropped into the vitreous cavity, we had given her an IVTA also. Thereafter, she was better. So that is the happy ending of case 1. But there are question marks after that. The actual story starts now. The patient came back 1 month after the surgery for vitreous removal of the vitreous fragments, lens fragments from the vitreous cavity, and she came back. When she came back, she had a recurrence of uveitis. The vision had dropped all along when she had suffered us for 9 months. She had maintained 6/9 and 6, but now she had a drop in vision after the vitrectomy. And on OCT, she had this cystoid macular edema with subfoveal fluid. And then we saw in detail with depression and found that this small piece of nuclear fragment was stuck to the pars plana region. There is no way to photograph this, that is why I put a schematic drawing there. And then she underwent surgery for removal of this small fragment of the nucleus which was stuck to the pars plana region, which was very difficult to visualize throughout those 10 months that she underwent the suffering, and it was also not possible to see this without depression. It was just a matter of chance that somehow we could at least see this and localize this at the 10th month follow-up. So we had to do a bimanual surgery for her because the surgeon had to depress in order to gain access to this fragment. Sorry about the video. And because this was close to the ora serrata, the fluid air exchange with cryotherapy to the peripheral retina was done, and finally her OCT came back to normal foveal contour, and the vision was restored to 6/6 and 6. And this is when I can say that it was indeed a happy ending. But what were the lessons from the case that we learned? We have to respect and address the complaints of the patient. The patient came to us with floaters, whereas because we saw the cataract, we jumped into doing the cataract surgery. This is something which we have to remember. Even if the patient has cataract, whatever the patient complains of, I think we should address that first. If we have a complication, the anti-segment surgeon who did the surgery should not conceal a complication just because he feels that it has passed off without any event. That is, although there was a PCR, probably he felt that it was okay to just pass it off as uncomplicated or uneventful, which is wrong. So we should practice an honest documentation. In fact, whenever there is a PCR, we should actually document what actually happened along with the PCR. We should make a note of how much vitreous was lost, how much of nuclear fragments went back, whether the epinucleus went back or not. And this has to be passed on. This information has to be passed on to the vitreoretinal surgeon for him to be able to, actually expect and anticipate what to do. And a depressed peripheral examination, I think, is a must in all cases of postoperative uveitis. You might be dealing with nuclear fragment retained in the past pinna region, as in this case. So in all cases of postoperative uveitis, maintain a high index of suspicion for nuclear fragments. This is the message that I want to give across to you. My case 2 is about an 8-year-old boy cross-referred with dilated pupils. He came with a history of sudden decrease in vision in the left eye of 8 days duration. He had occasional pain and redness lasting 2 months, and his vision was 6/24 partial in the affected eye. Slit lamp examination showed AC cells 3+. The fundus picture representation was not very clear to take a photograph of it. So this is a schematic drawing. This the left eye actually should have been on that side. You can see that there was the fibrous band passing superiorly from the optic disc for about 2 disc diameters superiorly. There was vitreous hemorrhage, and through the vitreous hemorrhage we could see that the peripheral vessels showed exudative sheathing or cuffing. Retrospective history, nothing forthcoming. There is no history of trauma. So this patient was diagnosed as having vasculitis, empirically started on oral steroids and topical steroids, and sent for investigations, the usual vasculitic workup that we do for this age group of patients we sent him for. At 1 week of follow-up after the starting of steroids, this patient had a mild clearing of vitreous hemorrhage. The disc, the fibrosis that was extending from the disc superiorly was better seen now, and peripheral vascular sheathing also was better seen, and the vision was still low at 6/24 part. So we decided to treat him empirically with, since the investigations had come normal, we thought that we should treat him with a row of anterior retinal cryotherapy for the vasculitis and the vitreous hemorrhage that had ensued following the vasculitis. We treated him with ARC. 1 week post ARC of the inferior part periphery, the vision was restored by 1 line. There was a clearing of vitreous hemorrhage, and at 6 weeks the vision came back to 6/9 with good clearing of the vitreous hemorrhage. That means there was a vasculitis which was a causative factor for the vitreous hemorrhage, and with the cryotherapy there was a resolution. So at that time we saw that there was a floating foreign body seen in the inferior retina. There were the peripheral cryomarks which we had induced, and we decided that this could probably be a case of an retained intraocular foreign body, although it was also in our mind that this could have been a nematode. So this is a case of an intraocular foreign body masquerading as retinal vasculitis. So with this in mind, we thought, now that we know the cause, we should go in and remove this foreign body. So surgery was undertaken 7 weeks after presentation. Intraoperatively, what we saw was that this site of entry was missed all along the first 6 weeks, and this track of cataract or the track of the foreign body in the lens had been missed. The entry wound and the localized cataract had not been noticed by us because the patient came with dilated pupils. I will tell you why we missed this. And this is the surgery which we did for removal of the foreign body. The small piece of foreign body, about 2 to 3 millimeters in size. It was not measured accurately, but then that is the foreign body which came easily with the 23 gauge cannula itself with the forceps. So retrospective history, boy would play regularly at a functional car garage. He was from a rural background and there was a tractor and a car mechanic next door, and that is where he used to go and play. It was an open area where boys used to go and play, and that is where he probably sustained the injury. At 4 weeks follow-up, his vision was 6/6 and fundus was stable like this picture you see here. But this is where the site of foreign body ricocheting was. When we saw the fibrous tissue on day 1, we did not wonder why this was there. There was this vasculitis, there was a vitreous hemorrhage, there was uveitis, but we didn't bother to find out or did not worry much about this fibrous tissue band, which is so common in intraocular foreign bodies, which usually develops between the site of ricocheting or site of impact of the foreign body and the disc. So what is instructive about this case? We should include a social history, a proper history where he goes to play. Even a boy who, a bystander of on the road or anywhere where work is going on. We have had cases where people have sustained injury while watching the road metalling, that is asphalting on the road, where they sometimes hit the stone. So such being the case, we should, I think, include a detailed history. Maintain a low threshold for EUV in children. See, what has happened is, this boy has come to us. We have not. He has come from another department, from the anti-segment department, with dilated pupils. So we thought we should look only into the fundus. So a detailed examination is mandatory. Even if it's a boy, if he is not cooperative, we should probably cajole him and try to see the rest of the findings, try to elicit all the findings that are possible to get in these children. Even during the cryotherapy that we did, which was under anesthesia, the anti-segment findings were missed. We just went in, saw, because we were biased that this was a vasculitis, we thought we should do the cryo. We didn't bother to see the anti-segment. This is actually a confession. This is probably a side effect of super specialization. So we should see the eye as a whole, the patient as a whole, and treat accordingly. So with this, I think, in any unexplained uveitis, we should consider foreign body as well. Thank you very much.
Thanks, Dr. Guru Prasad, for those excellent cases. We can have any questions towards the end if time permits. I do now request Dr. Mahesh, who is in the vitreoretinal department at Giridhar Eye Institute at Kochi, to present his patients.
Good morning, everybody. I will present uncommon presentations of a common disease. So this case has two parts. One is a 22. Both young people came in same week. This is a 22-year-old male, blurring of vision 5 days, history of fever, no systemic disease, vision 6/60. This is the fundus picture. You can see an area of something like vitreous was a little hazy due to vitreous cells. Sheathing is there, here it is visible nicely. Little more. Vascular sheathing is there and vitreous cells are there, and there's a retinoporoiditis patch. This is the other eye. Here also you can see some sheathing. This is the lesion. This is the angiogram. This is the angiogram showing sheathing and leakage. Periphery also, bilateral vasculitis. Nothing, MAN2 was negative, Toxo was negative, ESR was normal. So we were thinking about retinal vasculitis, toxoplasma, etc. and treated with steroids, vision improved. This is little more. Can you brighten this? This is pre-treatment and post-treatment. OCT before and after treatment. Now this is the main case that I am coming into. This is another boy, another man, 39-year-old, defective vision of right eye of 1 week duration, no systemic diseases. This is the finding. You can see similar yellowish subretinal lesion inferiorly, but vitreous is very clear. Left eye is looking normal, nothing much. So these are the two cases. This is the first case where there is a lesion like this. This is the second case. Here there is vascular sheathing, vitreous slightly hazy. Here it is reasonably clear. So you can compare and confuse. Here also most of the preliminary tests were negative, and this was also diagnosed or rather misdiagnosed as toxoplasma and Gare steroids. After 1 week, much better fundus. That lesion here is gone, yellow lesion is gone. This is the finding. But to our surprise, there was an inferior retinal detachment, exudative RD. And then we did an OCT and all, and it is a case of steroid induced or worsened steroid worsened central serous chorioretinopathy. This autofluorescence is very characteristic of central serous chorioretinopathy, hyper-autofluorescent areas, tract and all. So this basically I wanted to show that steroids can be given mistaking it for retinochoroiditis, and we have given stop steroids and gave placebo. After 2 months, the inferior retinal detachment gradually settled. So these are the points basically how you differentiate actual inflammatory vasculitis or retinochoroiditis from a fibrin CSR. This is actually fibrin. Usually this will be seen, fibrin CSR we are all aware of, it is usually seen in the macular area. We don't see fibrinous exudates in the periphery outside the arcade. So that was the main cause of mistaking this for a retinochoroiditis. And so this take-home message probably is careful fundus examination using indirect ophthalmoscopy and slit-lamp biomicroscopy. Look for vitreous cells, and if you start by mistake systemic steroids, review after 5 to 7 days always, and see indirect ophthalmoscopy. And so this is one case of central serous chorioretinopathy treated with steroid and worsened. So this is now coming to case 2. This is a 53-year-old man, defective vision of left eye of 1 week duration, and he is a diabetic. Visual acuity was 6/9 and 6/36, right eye, left eye. So this is the fundus photo and fluorescent angiogram. This is the right eye. This is a CSME case where there is NPDR changes. Fluorescent angiography shows leaking microaneurysms, and typical NPDR CSME. This is the left eye, another left eye also, NPDR cases, NPDR with CSME. But OCT showed a lot of fluid in the macula in the left eye, serous macular detachment in the left eye. Okay, the right eye has more of spongiform edema, little serous macular detachment, but left eye, a lot of fluid. Then we did a fundus autofluorescence, and we saw that hyperautofluorescent area along the macula, temporal to the macula, inferior, here also. So this has an underlying central serous chorioretinopathy also. That could be the cause for the large serous macular detachment. Go back, then we will see that this point is leaking profusely. It is not a microaneurysm. This point, while the other points are looking microaneurysms. So in fact, there is a point leak also with a superadded diabetic retinopathy. So in fundus autofluorescence is a very useful imaging in CSCR, and this hyperautofluorescence due to fluorophores in the disrupted photoreceptors in the subretinal space results in this hyperautofluorescent area, which can be very useful in the diagnosis of central serous chorioretinopathy. So CSR can coexist with other diseases, and large serous macular detachment in OCT may have to be treated with suspicion. You have to do this test to rule out any this thing. Intraretinal edema usually will be absent in pure CSCR, and fundus autofluorescence is a useful investigation. This is the take-home message from this case. Now going to the third case, this was a 74-year-old gentleman referred as a case of macular degeneration. Visual acuity was 6 by 24 and 6 by 60, right eye, left eye. So this is fundus picture, lot of RP modeling and degenerative changes are there. It looks like dry ARMD considering the age, 74 years. This is the fluorescent angiogram, RP window defects, and this looks like a pooling of dye in the PED and staining of some dozen. The OCT showed cystoid edema, disruption of ellipsoid line, and in the right eye. Left eye has foveal atrophy. This clinches the diagnosis. He had RP tract in the left eye. Right eye also has hyperautofluorescent area in the macula. So the patient is not having dry ARMD. He had a old CSR, central serous chorioretinopathy sequelae. AMD is not the take-home message is AMD is not the only macular degeneration in elderly, and we should remember that CSCR patient can also get aged, and CSR sequelae can be seen in elderly. Since and the treatment of both entities are different before labeling him dry ARMD. Thank you for the kind attention. Yeah, we have plenty of time since I finished very fast.
What is the reason why the fibrin disappeared quite fast after starting?
Probably CSR is inducing no. That location of fibrin in that fibrin CSR that usually we see in the macula, but outside the arcade I don't have any picture.
Clinically, it was not looking like fibrin.
We thought it is fibrin only after getting an X-ray developed.
Okay.
The picture was there.
Okay.
Yeah.
First case,
Yeah.
sorry if I have not listened to you fully. First, you showed two similar pictures.
Yeah.
The picture on the left was showing
Vasculitis and
vasculitis.
yeah.
And the picture on the right was, you said, was actually a fibrinous focal area where surrounded by SRF.
Yeah.
So, which case you gave steroids in this?
Actually, both cases we have treated with steroid.
Okay.
The other one resolved.
That
Right?
resolved.
Right.
This
Case is resolved. It is an inflammatory condition. This one went into X-ray development. So this is the first case and this is the second case.
Because you had seen
60-year-old male came to us, was a known diabetic since 25 years. Right eye, he had undergone vitrectomy elsewhere a few months ago and did not regain very good vision in that eye. He primarily came for opinion and management of that eye with defective vision. His left eye, he was quite happy, 6 by 24, but he had good reading vision, N8, and he had stable PDR post laser in the left eye. And the right eye had recurrent detachment under silicone oil post vitrectomy due to PDR. And we did a revision vitrectomy, we did membrane peeling and injected oil. Though the retina remained flat, the vision was quite poor. And patient continued to follow up with us regularly for periodic examination kept coming, and the left eye was normal. He was managing very well. Almost 2 years down the line, September 2012, then he came with blurring of vision in the left eye. Left eye was always asymptomatic till now. Vision was still 624 distance, but the near vision had dropped to N12. Cornea was clear, both eyes were pseudophakic, right eye had silicone oil, left eye ventricular pressures were normal. Can you write this? I'm sorry, originally the quality itself is poor. Right eye had flat retina under silicone oil with a pale disc. You see the reflexes you see are from the silicone oil. Left eye had a stable PDR post laser, you see a large area of proliferation which had become gliotic, and this was a thickened hyaloid phase which had totally detached from the retina, and it was free from the macula, and the macula, underlying macula, looked normal. And in fact, we had done OCTs earlier for left eye, it was normal. So when this patient presented with blurring of vision in the left eye, we thought, okay, it must have progressed to macular traction. But when we did the macula OCT, it was totally normal. There was no traction, no edema. It was not at all different from the previous OCTs. And this shadow here is mainly because of that thickened hyaloid phase which had cast a shadow on that he had had for a long time. It was nothing new. So there was nothing to indicate why this patient had decreased vision. So in summary, we had a patient who had a stable PDR post laser in his left eye, it was good eye, and he came with a recent drop in the vision, mainly in the reading vision. Pseudophakic patient, macula was looking normal, there was no macular edema, it was flat on OCT. So we could not really think of a cause for decreased vision. We looked at his systemic factors, we did his refraction. We kept on following him up for 2 weeks, 1 month, and then he came back after 1 month. His vision was same. He said still blurred. We also could not really decipher what was happening. But at one point of time, we had done OCT of the disc. This was the OCT of the disc in September, and we did notice that there was some gliotic proliferation causing some elevation of the disc tissues, but we did not pay much attention to that at that time. But when the patient persistently had decreased vision, that is to draw your attention to the gliotic proliferation causing traction on the disc. So when the patient continued to have blurring of vision and we could not identify any cause, then we looked at serial OCTs. That was in September and May. We could see that the traction had increased gradually over the 5 to 6 month period that the patient was being followed up with us. And by May, his vision had dropped to 6/36, when the distance vision had dropped. So this is when we came to the diagnosis. Can anybody give the diagnosis here? Well, to sum up, we have a patient who had a stable PDR post-laser, macular status is stable, no edema, no traction. Patient is symptomatic, very symptomatic, and gradual decrease in vision. The vision is dropping, and we are unable to find the cause. There is a gliotic tissue causing traction on the disc. OCT shows a clear-cut elevation of the disc tissue and the traction by the gliotic tissue. And serial OCTs during the follow-up also shows increase in the traction, and that's when we made the diagnosis of arteriopapillary traction. And at this point of time, we did advise the patient to undergo surgery. But patient had undergone already 2 surgeries in his right eye, and his outcome was not good. So he was naturally very reluctant to undergo surgery in his left eye when he kept on asking us, can you guarantee me that the present vision will not go down? And I would like to take you back to the fundus picture, what was there. I think if you look at the fundus picture, that was the patient with PDR, and you see this large gliotic proliferation which was there. And we could never categorically say that yes, you can undergo surgery, there is absolutely no danger of losing the vision. We kept telling there is a small risk that vision may go down if things don't work out, if we are not able to dissect the membranes, if the retinal breaks develop, you may have a problem. So patient did not make up his mind for surgery for several months, and ultimately after about another 3-4 months of repeated visiting, counseling, talking, ultimately patient decided, okay, I will take the risk, I will undergo surgery. We were able to circumcise the membranes causing traction on the disc, and we did inject silicone oil because I think being a one-eyed patient and there was one break in the superior retina, away from the posterior pole. But being a one-eyed patient, we wanted him to have vision, in the immediate post-operative period also, and therefore we injected silicone oil. And post-operatively, the patient had good vision with silicone oil, and silicone oil was removed in January 2014. Subsequent to this, he has had 2 follow-ups, and patient is very, very happy. Patient has regained a vision of 6/18 N6, and this is the disc picture of the disc following surgery. We are able to remove the membranes completely, and this is the OCT of the same patient following surgery. So with this, I would like to just present another 3-4 cases of similar variety, and maybe we can have some discussion on this topic. 61-year-old male, again drop in vision, recent drop in vision from 612 to 624 patient, presented to us with PDR. He had undergone laser. He maintained reasonably good vision, but you see how there has been extramacular traction, and this is the presentation. Macula is flat. There is no macular traction. There is no threatened macular detachment also, but look at the disc. And going from our experience with the previous cases and our awareness about this condition, we made a diagnosis of vitreopapillary traction. Patient underwent vitrectomy, and this was the pre and the post-op picture, and this is the OCT of the same patient. You can see patient regained 6/12 vision. Another example of a gliotic proliferation on the disc causing traction with a decrease in vision to 6/60. Following vitrectomy, we have relieved the traction. You can see the OCT picture. One important tip I would like to give you when you are trying to do something like this, in a case like this where there is a traction, we do not really pull the proliferation of the disc. I don't think that is recommended. We don't know how strong adhesions are there between this gliotic proliferation and the disc tissues and whatever tissues are there at the disc. Our aim is to remove the vitreous hyaloid phase and circumcise the tissue on the disc, like what we have done here, so that the tractional component, what you see here, this anteroposterior traction, is relieved, and that's our aim when we do surgery here. We never pull it off like what we do in an ordinary case of a PVD induction. So please keep that in mind in case you ever happen to do surgery for something like this. And another case with proliferation, traction, some nasal dragging, and you repeat here also the vision improved to 6/18. And all of them, let me emphasize here that we did see the patients for at least 1 month or even 2 months before we arrived at the diagnosis. We followed up the patient when we were sure that vision was not improving, it was gradually dropping, and then we made the diagnosis and we discussed the surgery for the patient. These are the OCT pictures of the 4 patients, and that is just a schematic to show how the traction on these axonal fibers, the ganglion, the fibers of the ganglion cells, could cause a decrease in vision by this tractional forces. And so in conclusion, I've just presented a series of cases where vitreopapillary traction was diagnosed as a cause of decreased vision. All of these were patients with stable PDR post-laser. The clinical features in OCT of the disc can help us to diagnose VPT when we rule out all other causes of, I think it's a diagnosis of exclusion, I would say. And once you are sure that it is the tractional component on the disc that is causing the problem, vitrectomy should be considered. And till date, we have done vitrectomy for about 7 cases out of 10 that we have seen in the last 1.5 to 2 years. Thank you.
Patient is probably likely to benefit from relief of the traction and improved disc perfusion versus a situation where there is a coexistent ischemia. Do you think anything in the VEP may, I don't know anything about it, do you think anything in the VEP may throw up a clue and segregate the 2 groups?
That's a very good question, and this what has come to us. Whether VEP can distinguish those patients who are likely to regain vision or those who cannot regain vision because of the ischemic component is what your question. I don't know whether it can distinguish between the 2 groups, but my own belief is that VEP can show that there is some optic nerve dysfunction. But whether it will distinguish between the two groups, I am not sure.
Yes, it is a very
And it's the answer lies in the history taking. If the patient has
With this,
the answer lies in the history taking. If the patient has a recent onset of the complaint that it may be because of this factor, rather than
patient, I think.
So more than that, I think if there has been a previous history of a precipitous drop in vision, suggesting an ischemia like a non-arthritic AIOA.
The thing is, if the patient is complaining that I have suffered a visual loss in the last 2 months or 3 months or maybe 4 months, you can go for the surgery. But if the patient is saying that, oh, okay, I am having this since 2 years or maybe.
I think the recent drop in vision, your point about AIOA is well taken, but I don't know. If in an eye like this with gliosis on the disc, stable, if a patient develops AIOA, I think it will be very difficult to diagnose that. I have not really come across.
The only other thing which I think we may exclude in future is that macular ischemia. If the OCT is normal,
Macular ischemia is other possibility. Then
proceeding to the
that's a possibility. But macula look clinically before and after also normal. These patients all were treated with us by us only for laser and all that. So we had the pre-op photographs, pre-laser photographs.
Worsening over recent past.
Yes.
The long-standing end-stage burned out PDR, if such a picture is we did not operate.
Correct. Yes, I agree with you.
The point is exactly.
Yeah. Correct.
the drop in the foveal capillary network. That's the thing I think which we see. We have done 10 cases, but if we do 100 cases, then we will land up in a few cases of macular ischemia. So
It's possible, yes. The macular ischemia, in the absence of traction or edema, macular ischemia should be kept in mind as a cause for decreased vision. But only my only point is that macular ischemia, generally you would be able to see some occlusion of capillaries near the arterioles near the macula. Maybe an FFA could be a useful workup in these patients.
FFA and probably visual fields. Visual fields also. If it shows a pattern type of an altitudinal defect.
EDR, laser treatment, visual field light.
Visual.
Yeah, why I'm asking this question persistently is because despite any amount of counseling, explanation and all that, you will have to deal with the patient post-operatively, and if the vision at least doesn't remain stable, then we have a tough customer on our hand and very difficult to convince.
In the literature, there is a diagnosis mentioned as fractional optic neuropathy. This is the same which
And only was there anything intraoperatively that's because many of these patients, the moment you relieve the traction on the disc, intraoperatively you can see the disc perfusion getting better. So was that noticed in?
I can't say we did.
Thanks, Dan. The first patient is a 52-year-old gentleman who presented with blurred vision in both eyes of 4 months duration. He had no other significant ocular or systemic history. He had a best corrected visual acuity of 618, less than N36 in both eyes. The anterior segment and the intraocular pressures were normal. The dilated posterior segment showed this picture. Bilateral central serous retinopathy with some amount of fibrin. The flavor of the morning seems to be central serous retinopathy today, but I can assure you the remaining two are not CSRs. So this was the picture in both the eyes. And this was the fundus fluorescein angiogram showing multiple PEDs in the right eye as well as the left, and some points of leakage as well. We explained the diagnosis to the patient, and the prognosis was explained, limited treatment options, and the variability of visual results with laser treatment was also explained. We did take a history of any oral drug intake in the form of oral steroids, but there was nothing forthcoming with that as well. He presented 10 days later as he was contemplating on what to do, complaining of further drop in vision. And at that time, the situation had worsened, the fluid had increased, and he had inferior detachments as well in both the eyes, with an increase in the fibrin, subretinal fibrin as well. The question was, what next? accidentally happened to notice this in his shirt pocket, and I asked him whether he had been using this. He had been a chronic smoker, he was a chronic bronchitic as well, and he said some friend of his told him that this would give relief, and he had been using this right, left and center without any supervision. And we discussed this issue with his chest physician and switched over to non-steroidal drugs. And lo and behold, 3 weeks later, this is the fundus picture of this patient. And the inferior detachments also had settled down nicely, and his systemic condition also seemed to be better with the other immunomodulators. Decrease nitric oxide in the local milieu, which is a natural vasodilator, delays RPE healing, which may occur from whatever reason. And also it alters the RPE polarity. These are some of the mechanisms by which steroids induce subretinal fluid accumulation. Rarely bilateral CSRs may be related to Cushing's syndrome. Changing to other antihistaminics and immunomodulating drugs, and even a decrease in the dosage of steroids, if it can't be completely removed from the treatment, often aids resolution of CSR. So your take-home message was, even a steroid that is being taken for nasal allergy or skin ointments being used for the patient for some skin ailments have been reported to cause central serous retinopathy. One should be cognizant of these facts. The case 2 is intriguing one even at the end, so I would like your inputs on this. This is a 28-year-old gentleman who presented with blurred vision in the right eye for 2 months duration. There were no other associated symptoms. His vision was 624 parts N8 in the right eye. He had an RAPD. The rest of the findings were all normal. And this was the fundus picture in the right eye. He had these whitish cobblestone-like looking appearance in the macula, and also in the nasal and the superior aspects. Almost the whole of the posterior pole was looking somewhat pale, but not uniformly pale, but somewhat it had a nodular looking appearance. Left eye was normal, and these are the angiogram pictures. You could only see the silhouette of the retinal vessels against the background of a faintly appearing choroidal fluorescence. Even at 34 seconds there was no dye in the eye. None even at 44, only a hint. And then you can see the leading edge of the dye in the arterioles at about 1 minute. In a sense, it was delayed ocular circulation. And the whole of the retinal vasculature was filled up only at about 3 minutes. We thought of, being a young patient, we thought of investigating him for other parameters as well, but nothing was forthcoming even with that. So we were really at a loss to know what's going on in this young patient. So whether it was migraine, though there was no history of migraine, there are reports in the literature which says that retinal arterial vasospasm, even in the absence of definitive symptoms of migraine, can be causative of such a picture in the young. Whether it was ocular ischemic syndrome, again to explain OIS in a young patient without any other findings was hard. So we really don't know what's going on in this patient. He came back about a year later for a follow-up. His his fundus picture was a lot better with a better foveal, defined foveal reflex, and those whitish-looking lesions, ischemic-looking retina was not there. But he continues to have delayed ocular circulation even now. So we don't know what that is. I would like your inputs on that probably at the end. This is the last patient. This is an interesting angiographic phenomena that we noticed in this patient. He happens to be a 51-year-old gentleman who came with sudden blurring of vision in the left eye of 1 week duration. There was no other significant past ocular history, but he was a diabetic and hypertensive for the last 7 years on treatment. And his vision was 618 N10. The anterior segment was normal, pressures were normal, and the fundus examination revealed a fundus picture like this, CRVO-like picture with whitening above and nasal to the fovea, probably suggestive of an element of ischemia there. What's the diagnosis would be a mischievous question for this audience, but is there a serioretinal artery occlusion in this patient is what we thought. he does have a cilioretinal artery here, and this seems to be along the cilioretinal artery. We did a fluorescein angiogram. Please disregard the dark shadows; those were unfortunately artifacts at that time in my camera. You can see that the retinal arteries have started to fill up, but the cilioretinal artery which is there is still not filling up. It ought to have filled up because it fills up earlier from the choroidal circulation, but it's not filled up. There is a hint of the cilioretinal artery getting some dye at about 34 seconds. I have put full frame photographs to draw your attention to this interesting phenomenon which we noticed. The dye has gone back at 35, there is no dye. It's back in again at 36, and then in the subsequent frames it's gone. So this stuttered blood flow in the cilioretinal artery, and then it probably filled up fully only at about 1 minute 11 seconds in a stuttered manner. Late disc staining, of course, related to CRVO. So the diagnosis was a non-ischemic CRVO with impaired cilioretinal artery blood flow. When I looked up the literature, we got some useful insights into this. All other systemic investigations were normal. It's not a focal blockade because after resolution of this cilioretinal artery impaired blood flow, these patients have been subjected to nerve fiber layer analysis and visual field analysis. There's been no residual scotoma or retinal nerve fiber layer thinning. So here proposes that there's no focal blockade that may occur, that does occur in these patients, contrary to what may happen in patients with AIOC, where there is a focal blockade. It is the increased venous pressure associated with CRVO against which the cilioretinal artery is pumping that causes the stuttered blood flow. And in this regard, it would be useful to note that the cilioretinal artery pressure has been estimated to be about 55 millimeters of mercury, and the pre-laminar CRV pressure is about 62. The post-laminar CRV pressure is just about 10. So as it is even in the normal state, the cilioretinal artery is kind of pumping uphill. And in this situation where there is increased backflow due to a CRV, it has further more pressure to counter. Add to that the respiratory swing, what has been called as the respiratory swing. The blood pressure decreases during inspiration and then increases during expiration naturally. So these factors may all be acting in concert to cause that stuttered blood flow which we saw in this patient. About 8 months down the line, his fundus findings had resolved reasonably well, and there was nothing nothing in the fundus left to say that the patient had a permanent cilioretinal artery occlusion. So this was an angiographic curiosity which I thought I will show you. Thank you so much for your patient hearing.
Direct history of steroid intake and indirect history of whether the patient has asthma. Find out is whether he fishes out any steroid inhalers, any history of skin diseases or arthritis. Apart from this, we also ask patient of for history of taking any alternative medicine. Alternative medicine sometimes don't reveal because you are allopathic doctors and they don't want you to know that they are taking homeopathy or Ayurvedic. Sometimes these homeopathy medicines are spurious. I'm not talking about homeopathy medicine per se, but some of the medicines can be spurious with, they contain steroids. So we have to also take a history of patient taking alternative medicine. I think that is one thing we have to keep in note, because we have had many patients later on admitting that they are actually taking homeopathy medicines, and when they were asked to stop, the CSR resolved.
The second case, any inputs, Murli or Krishna?
One other thing is that obviously there is a drop in the pressure and the blood flow in the right. It was in the right eye, right?
Which eye? Yeah, the second case?
Yes, second case.
Right, yeah.
So if you've not seen it in the carotid and proximally the block, then it's further distal. So you need to go to the subclavian and from where the subclavian comes off from the aorta. Because you've not seen the entire tree yet.
But his peripheral pulses were all normal, blood pressure was normal. If there was something down, wouldn't you have expected something like a pulseless or some problem with the pulses, etc.?
No, the fact remains that the pressure on this side is low. You still need to explain that. So until you see the entire tree.
Or what would you suggest?
So you have to go to the subclavian and check. Mouth of the subclavian, because right one I think comes off, carotid comes off from the subclavian. And then to where the aortic arch, where it comes off.
What tests would need to be done further?
No, you will have to go back and check the Doppler blood flow at the subclavian for what you will do for a Takai also basically. Because it could be from where the big arteries are coming off also. It need not be along the vessel itself. So if you have not seen the entire tree right up to the heart, you have not checked everything yet.
But with nothing done so far, 1 year down the line, his right eye is better now, but it continues to have delayed arteriovenous, arm to retina circular stem is definitely long. But his fundus picture is better without having done anything. He's 28 years old, so it's quite enigmatic.
I understand that it seems to be better also.
ESR was normal, I think some 10 or something like that.
Inflammatory lesions can go back and forth. If we're looking at, again, arthritis-like condition, it can worsen and improve. It doesn't always say that
Remain
it
stable.
will be a normal. We're not looking at a constriction alone.
Thank you, everybody. I would like to thank all my colleagues and the AIOS for giving us this opportunity. The only negative point about it is the sparse audience over which we have really no control. And we have also finished in time, so that's another good thing. Thank you so much. Thank you, everybody.